Can you guys hear me? I need a text or something from someone.
Daniela, we can hear you now. We're seeing a lot of yeses in the chat box here, so I think we're good.
That sounds great. Okay, sorry. Sorry for that technical difficulty, but we're off. All right, folks. So this is Daniella Cameron from Preble Street. Thank you, Sarah, for those introductions, and we're really excited to be here today to talk about some of the work we're doing here in Maine. And so I'm going to pass it over to Zoe Brokus to talk a little bit about the overview of the opioid crisis in Maine and to talk about the work she does.
Yeah, thank you. So, you know, my daily role is working in the needle exchange program. And so really, you know, it was back in 2014, 2015, when we started getting a lot of feedback from our clients in the exchange, really talking about change in overdose and the change in they were seeing. So, you know, fast forward to 2017, overdose deaths were increasing every year, and we were up to 418. The majority of those were polysubstance users, which is pretty standard with most of the people that were seen in the program, primarily opioids and benzos, or opioids and some kind of stimulant. And in our program, we about naloxone, we're also able to track the overdose reversals that we see in our program. We're the largest needle exchange program in the state, and we're also the southernmost. So that means many things, but one of the things that's important in regards to this topic is that we see a lot of people coming and going across state lines, whether it's to New Hampshire, Massachusetts, or New York, you know, to buy drugs to bring up here to sell them cheaper, or to leave to, you know, go to treatment, or to, because they're incarcerated across state lines, something like that. But we have a lot of people that access our program, and our numbers are increasing every year. We really try to make our program as accessible as possible to people. You know, we offer free HIV and hepatitis C testing. We have an STD clinic on site, and we're able to offer self-swabbing for chlamydia gonorrhea screening, which is particularly helpful with our population of folks sometimes. We do a lot of education around, obviously, overdose prevention, but also infection prevention, abscess care, wound care. We are a clinical setting, so we do have some medical support throughout the week, which is helpful. And then we work a bunch with our community. And so, you know, the referrals piece is not just handing somebody a brochure and sending them on their way. It's really making sure, you know, that I have solid connections with all of these different agencies in the community, so that if there is a need, I'm able to directly connect that client with an actual human being. I think is vitally important. So, I mean, we talked a little bit just in terms of our program being the largest. I mean, these numbers look small compared to other states, but they're actually pretty significant for us. We did see a little dip in our numbers in 2015, and that was mostly due to funding. But since then, we've continued to increase, and I imagine we're going to exchange over 200,000 needles this year, and hopefully see about 1,000 unique individuals. You know, we're a standard needle exchange program, but for people who don't know what that is, we provide clean syringes and supplies to support and encourage the safest injection event possible for individuals. And that varies person to person, obviously, and really dependent on their situation and their environment. But the items I listed on the screen are what we always offer, and people can kind of choose to take all of those or some of those based on what they're using and based on really like I said, their environment. And then the naloxone is big, and I'll talk about that for a minute. As we saw this increase in overdose, we started really getting a lot of requests from our clients to provide naloxone. Naloxone is also known as Narcan, and it really quickly and effectively reduces somebody's likeliness of dying from an opioid overdose because it blocks the effects of the opioid and allows the person to start breathing again. So many needle exchange programs across the country, across the world. I mean, this is a big topic that many people are aware of right now. But here in the state of Maine, it's taken us a while to be able to distribute. So it wasn't until 2015 that we were able to start handing out Narcan or naloxone in the exchange and gathering data on what our clients were seeing. And that was so helpful for us as we were sort of experiencing this change in our community of like, what is going on? We didn't have great confirmation that it was fentanyl that we were starting to see, but that's what everyone was telling us. And the overdoses started to look different, and we were able to really track that. So we know that last year in our program, our clients reversed 291 overdoses in 1 year, and those were the ones that came back and reported them to us. So we imagine that number is much higher. But our goal is to continue sort of distributing and continue to have that number increase. I mean, we'd like to see the reported reversal numbers decrease in a way, but ultimately it also shows that the access is there. Maine is a big state, and we see people from all over, and so we know our kits end up way outside of Portland. Even though about 85% of the reports are coming from Portland, they're really getting out into York County, which is south of us, and along the coast of Maine, and really all over. People come to access our program and then are able to also get Narcan and all of these other support services as well.
Hey everyone, this is Caitlin. I'm going to talk just a little bit about Preble Street before Daniella shares more specifically about our anti-trafficking program. So just briefly, we're, for those who are not familiar with Preble Street, we're a social services organization. We've been around for a little over 40 years. And so our mission is all about providing low barrier, actually barrier-free services to folks experiencing homelessness, experiencing poverty, and to try to connect people with solutions for those problems. So we have a range of different programs across the state. The first program on this list is the Resource Center. So that's a drop-in site. People can walk in. We have a soup kitchen there that provides 3 meals a day. And there are a range of services, including bathrooms, showers, mail, case management, and basic needs items like, clothing, a pair of socks, and really connection. We try to help people get connected to the services and supports that they need. You don't need to show an ID to access any of these services or, have insurance. We're really trying to meet people where they're at, no matter what they have going on. So that's just we'll keep it brief to sort of what we do. And then to talk a little bit about how we have responded as an agency to what we've been seeing over the past several years. This is not something that we thought we would be doing as non-clinical staff, but the truth is that people who are homeless are at much higher risk of experiencing an overdose than those who are not. We also see that a lot of the folks that we work with are frequently incarcerated, frequently hospitalized, and what we're seeing is that anytime somebody is out of the community, their tolerance for use goes down, which puts them at risk of overdose. But they're also out of that sort of community loop for a minute. And so it's a lot harder for them to know where they're sourcing their substances from, which can also add to the overdose risk. So all of that to say, this is something that's absolutely affected the community of folks accessing our services. And so as a result, we've responded by making sure all of our program staff are trained to identify overdoses and respond to them. So we, not only respond to overdoses, we're also training our staff to talk to folks about their use, talk to them about programs like the needle exchange, about where they're sourcing, their substances, who they're using with, all of these different things to try to keep people safe and keep people alive. So we stock all of our programs with Narcan and train staff on how to use that. And so since 2015, we've reversed over 80 overdoses at our program sites. We've also made some changes to the physical spaces at some of these programs, including the resource center. So bathrooms, have a staff person who's there in the area to monitor them, and we have motion sensor lights so that way you can tell if someone becomes unresponsive once they're in the restroom. So this is a decision where we're always trying to really balance someone's ability to access a private, dignified space to use the restroom, but we also want to be cognizant of the fact that we do have a number of people who are injecting opiates, and we want to be able to keep someone safe and reverse the overdose if they do use on property. So we are a low barrier space. We're not a safe injection site, though. We're not. It is like against our community guidelines for someone to use on property. But if that happens, our first step is to initiate our overdose protocol, call 911, administer naloxone. That's what we do first to keep people safe and alive.
Great, thank you. So this is Daniella again, and I'm going to spend the next couple slides talking about the trafficking work that we do, the anti-trafficking work we do at Preble Street. So just to make sure that we're all on the same page, I'm sure everybody on the call has a pretty solid definition of trafficking, but I feel like it can never hurt to say it more than once. So when we're talking about trafficking, we're talking about an economic crime. When a person is compelled to engage in some kind of labor, including commercial sex work, through force, fraud, or coercion. And we're also talking about trafficking when any person under the age of 18 engages in commercial sex work. So the Preble Street Anti-Trafficking Services was established in 2013 after we had been seeing a number of youth in teen services in the program that provides services to homeless youth. We'd seen a number of youth that were being they were caught up in really exploitive work situations and exploitive relationships, and felt like it was important for Preble Street to really dig deeper into the understanding the issue of trafficking and how it relates to the folks that we serve. And to figure out solutions to addressing the issue of trafficking and supporting survivors. So we were awarded funding through the Department of Justice Office for Victims of Crime at the end of 2013, and our program started then. And the work that we do with survivors of trafficking is always client-centered. We use an empowerment philosophy that we believe helps support access to any kind of services, whether it's the intensive case management services or mental health services or legal services, and ultimately supports a survivor's right to make their own choices. So everything we do, from where we meet the client, how we communicate with the client, it's all up to them. Whether we're texting, whether we're meeting in person, whether we're asking them to come into our office for an intake, or we're meeting them in the jail for an intake. It's really everything that we do is really driven by the client. And as all of our programs at Preble Street, and as mentioned in our mission, our work is grounded in three sort of major philosophies. One is about low barrier and decreasing barriers to accessing services for any person experiencing homelessness, hunger, or poverty. We use Housing First, not only in our 3 Housing First programs, but also in every kind of case management and interaction, right? We believe that housing is a human right, and it's the place to start, whether it's in terms of treating mental illness, treating substance use disorders, that a person can't begin to really work on any of those identified goals without having a safe place to sleep at night. And then, of course, that goes along with that is all harm reduction in the work we do in helping mitigate risk. So I mentioned this I mean, I think Sarah mentioned this in our in her introduction, but so since the program started, we've worked with over 180 survivors of human trafficking. The majority of the folks we've worked with were trafficked for commercial sex, although I don't think that's necessarily an adequate representation of the issue of human trafficking in Maine. It's just really where how people are being identified. About 8% were trafficked for another kind of labor. The majority of the folks we've worked with were over the age of 25, a surprise to us when we first started the program. In teen services, we thought we were going to be working with a lot more young people, and that has not been the case. Almost 90% did not have any stable housing at the time of intake, and 67% at intake identified having a substance use disorder, and of that 67%, 86 of them, so almost 90% of those were opiate users. So the services we provide, you know, in addition to intensive case management, we work across the state to provide training and technical assistance, and we partner with lots of different agencies, including the Portland Needle Exchange, to provide the most comprehensive and holistic approach to meeting the needs of survivors of trafficking. And then most recently, in October this year, we were awarded a new grant through the Department of Justice to provide low barrier, rapid access medication-assisted treatment to survivors of trafficking with opiate dependence. And that is a really exciting new project that we're going to be working on, and was really modeled off of a program of health services that Caitlin's going to talk about next.
So Preble Street Health Services has a couple different programs, and a program that was just established last year as a partnership between Maine Med and Preble Street is called the Learning Collaborative. And this is a place that really has two purposes. So one is just to help improve health care for folks experiencing homelessness, as well as access to, you know, a range of different options, whether that's primary or specialty care. And then the other purpose is also to educate future healthcare providers about the population. So we have medical residents. This academic year, we'll have 40 residents that come through, and they are getting some clinical time with patients, but really the purpose of them being there is to get a sense for, you know, what people are dealing with. They get to see the resource center, see the soup kitchen, see Oxford Street Shelter where people sleep, find out about programs like the Needle Exchange in the community. So that way they're really understanding the barriers that people face, as well as the resources that are there. And that's all, you know, to help improve care, and also in regards to substance use disorder, really to help fight stigma. So that way when someone walks into the, you know, emergency room or into a primary care setting, they have a doctor who has some understanding of what they're going through before they walk into their doors. We also do provide some healthcare, and this is all from Maine Medical Center staff on site for just really basic care, but we're not a primary care site. We help connect people to primary care, and there's a really wonderful team of on-site medical social workers who help people apply for health insurance, make appointments, and generally coordinate their care. So this site works in collaboration with you know, staff from Preble Street, staff from Maine Med, to really provide some wraparound care for folks who are most vulnerable. So the Learning Collaborative is sort of the main program under health services. But then there are also two additional programs that the focus here is primarily on substance use disorder. So we did have a one-year program through a one-time funding source where we were able to provide direct service to clients. And a lot of that service was around connecting people to medication-assisted treatment. So I'll refer to that when we talk about our case study in a minute, primarily as MAT. So I'm assuming that's familiar to most folks on the call, but for those that it's not familiar, most common in Maine are methadone and Suboxone. So those are two medications that people can take on a daily basis, and that helps them, you know, basically it's a medical treatment for opioid use disorder. This first program provides some additional supports in terms of case management and connections to other community-based supports as well. We have another program that it's a pilot program that we're working on right now in partnership with our federally qualified health center in the neighborhood, Greater Portland Health. And this allows access to Suboxone on a daily observed basis, which many of the Suboxone providers in the Greater Portland area are really reluctant to prescribe to people experiencing homelessness because of concerns about diversion and people not having a safe place to store their medication. So this program has been really important to help increase access to Suboxone. And it also takes a low barrier approach, so that way people don't get exited from the program for things like polysubstance use, positive drug screens for substances, and instead they're able to remain in the program and remain in treatment. So this second program is really new. It just started this year, and it's, we're hoping that it will kind of continue to help change the landscape for folks like the person we're going to talk about in just a minute.
Want me to go?
Yeah.
Okay, so this is Zoe, and so we're going to talk about a case that really, I think, highlights the collaboration of our programs. And so we're going to refer to this client as Amanda. And all of this started back in November of 2015 when Daniella and her team came to my office, India Street Public Health, where the Needle Exchange Program is located in Portland, and provided a training for staff about, identifying victims, identifying signs of trafficking. And Daniella and I had been working together for a while, so some of this information I already had, but I really wanted to make sure my whole team had as well. And it wasn't long after that that two people, a couple, came into the exchange program, Amanda and her partner Rick, and I had been working with them for a while. They had previously been living pretty far away in York County, and I was able to get supplies to them. I would meet them at like the park and ride off of the highway and get them supplies, and we sort of built a relationship that way. They eventually made their way up to Portland, and really the first sort of red flag that went off is that Amanda's partner, Rick, he was the one who brought this up, and he said, she's too freaked out to tell you, but like something really awful just happened, and we didn't know where else to go or who to talk to besides you. And so they told this story of the situation that had happened, in which Amanda had basically been asked to drive across state lines, to drive some substances across state lines. And somewhere along that interaction, things became very violent and she was assaulted. So they presented this to me. She still was not speaking at this point. She was just like completely freaked out. And at that point, I had a better relationship with her partner anyway. We just communicated more. And so he sort of said, like, I know something happened, like, and it kind of started down this path of like, I don't know if she's just like doing something shady and cheated on me, but like you could tell by the way she was responding to the story he was sharing and her inability to even like speak about it. It was just very clear that it was more than just like somebody trying to get out of a situation with their partner. So we continue to talk about it. And then, I really felt, especially I think it's really important for people who are working in a low barrier or no barrier setting and really trying to encourage trust and positive connection. Like sometimes you have to remove yourself from that referral in a way. And I knew there was only so much I could do. Like I had nothing to offer them except this like incredible resource, right? So I reached out to Daniella and I was like, I have no idea. Like, I don't know if this is even something you could work with, but, would you be interested or willing to come talk to them and screen Amanda and see if this is something, because she's saying that she wants resources and she's scared. At this point, she'd like kind of started to talk a little bit. So I, made that connection. And then And then Daniella was able to come to my office and meet directly with them, which was like exactly what they needed. And it probably wouldn't have happened if we weren't able to make it happen like that.
Yeah. And then I'll just, before Caitlin was the primary point person for Amanda over the last 3 years. But after I met with Amanda at Zoe's office, and started asking some of our screening questions, it became immediately clear that she had been trafficked, and that the trafficker was actively looking for her after she had escaped the situation. So there were significant safety concerns that she was presenting with, and so we worked, and a real fear by both Amanda and Rick of law enforcement. Obviously, Rick had a history of being involved in the criminal justice system, and based on what Amanda had experienced and was forced to do in addition to the commercial sex work, she was really worried about reporting to law enforcement. So we worked pretty quickly to get her into a safe place to stay, and then within, I think, a week or two, she was wanting to report to law enforcement, and we connected her to an attorney who agreed to work with her on a pro bono basis and supported the process of her reporting to federal law enforcement what had happened. And then I'm going to let Caitlin talk about sort of the work over the last 3 years.
Yeah, so I'm going to talk a little bit about sort of what case management and what safety planning looks like for Amanda. And Zoe, please chime in, and I might look to you in some moments. And then we are going to leave some time to have some Q&A. But just before I begin, I just want to frame this by saying this is not a typical sort of survivor story in that we're presenting someone who went through a sort of A to B pathway in which we connected with them, they had a substance use disorder, they connected to resources, they got into treatment, and now they're living an abstinence-only life. That's not Amanda's story, and that's actually not the story of a lot of folks that we work with. And so I just want to say that from the get-go. Amanda has a lot of reasons to use substances, and our goal in working with her is to continue to offer her options that will keep her as safe as possible, that will keep her from being in another situation where all of her agency and power and control were taken from her, which is what happened when she was trafficked. And we also wanted to make sure she had options so that way when she was using drugs, she was able to be safe, and those around her were able to be safe as well. So that's like a really important thing we want to kind of highlight. So over the past 3 years now, this is someone who had never been engaged in commercial sex work before. So this was, the trafficking experience brought up a lot, a lot of shame. There was a lot of trauma associated with the assault, but the substance use disorder was not new. So Amanda was someone who had used for a long time. She had a really extensive history of grief and trauma, a lot of loss within her family as a teenager and a young adult. And so just very, very few natural supports, and really no experience with employment or with regular access to healthcare at the time of intake. And so, our work with her, as Daniella said, was immediately around, safety, getting her safe, getting her secure. So over the 3 years we worked with her, she was housed in 3 different shelters at various points. She, stayed at the domestic violence shelter. She stayed at the city shelter in Portland. She also stayed in a women's shelter run by Preble Street. And then, through our work with her, she did get a housing voucher. She was independently housed for almost a year. Mm-hmm. So these are, some of the things we worked on around housing. We also worked on connecting her to, an income stream. So she'd never been employed before, felt a lot of shame around not having an employment history. But what we found was, working with her on Social Security disability application was really challenging. really severe depression at times. And that depression kept her really isolated, really disengaged. And I just want to emphasize what Zoe said. If this referral didn't come to the needle exchange, I do not think this person would have accessed support, because her depression would become so severe that she would really isolate and have a very hard time engaging with providers. So that was something that we, weren't able to be successful with in terms of connecting her with income. And then another big thing we worked with her on, of course, was, her substance use disorder. So she was someone that, heroin was her primary substance of choice. And, she had been an IV user for years. And so in our conversations with her, we would offer, a range of different options for her for treatment. Which I will say, sitting here in 2018, those options are different than they were when they first started working with her. So I really wish we had had access to a program that was low barrier and that offered, supervised or, observed daily dosing of Suboxone, because we didn't have that to offer her at the time. And so what we had to offer her were a few different things. So Amanda was connected at one point to a private doctor that she saw monthly. So she'd walk out of there with a month of Suboxone, which, for those of you who don't know, especially a couple years ago, Suboxone had a really high street value. And so here's this person who's, gone through all this trauma, who has no income, who is homeless, walking out with, anywhere between $800 to $1,000 in street value in her pocket. And it's also the same thing that's going to, keep her feeling okay and not really sick from withdrawing from opiates. And so Amanda struggled with that. And she would, frequently, medical professionals use the term diversion, right? She would divert her prescription, meaning she would sell it on the street to cover her basic and to make sure that, she had what she needed. And so that really didn't end up being successful for her. She wouldn't be able to hang on to the medication to make it last through the month. And she wasn't engaging in any kind of supportive treatment. So that was one of the options that happened. And then she also had 2 different periods where she was in an intensive outpatient program. And what happened at those times is, when her use would start to stabilize, all of the trauma, all of the mental health stuff would just rise right to the surface. And, a lot of this had to do with the trafficking experience. But there was also a lot that predated the trafficking. She had so much grief, so much loss. And when she wasn't using opiates, that would come right to the surface. And it was, really heartbreaking to see. And there was very little movement on her federal trafficking case. So she had really a, lack of closure from the case, sort of constantly feeling like she was in a standstill. And then when she would get to these periods of recovery, she had periods where she was abstaining from substances and, just trying to take her medication as prescribed. She would go into these very severe depressions and was frequently offered, the option to go to a residential program, to go to a hospital, to call crisis. But Amanda had been hospitalized as a teenager for suicidality and had a bad experience. And so she was very clear with Danielle and I, with our federal law enforcement partners, with, attorney at one point. The word she would use was, I'm not going to get better in an institution. And so, she would just make that really clear. And so as a provider, it was really challenging to, sit in that discomfort of someone whose use was getting increasingly chaotic, who was, potentially at risk of overdose, but who was also really clear about what she was and was not willing to do in terms of, what was best for her and her recovery in that moment. And so that's where I just want to, again, kind of turn back to Zoe and talk about the needle exchange, because it was so important that she be able to have, non-judgmental supports to keep her as safe as possible, especially so once she got housed. So, with all of this going on, with the depression, with everything up in the air with her trafficking case, she was able to get a voucher and get housed and had an independent apartment. And in some ways, right, that actually, it reduced a lot of the risk and made her more safe. but now she has a place to stay, and so she has a place to use as well. And so that, you know, sort of changed the game in some ways in terms of our engagement with her. We were no longer focused on the housing, but trying to keep her housed. But that also meant that there would be times where we might not see her for a little while because she was having people kind of come in and out of her apartment. And so, you know, the way for her to stay safe was to keep engaging with the exchange.
Yeah, and I would say, you know, even though the challenges were monumental and the progress may seem like it was slow, I have to say it was incredibly amazing to watch her transform during this time, because yes, she continued to use, she struggled with her use, but I mean, she got housed and she was connecting with caseworkers and really trying different things. I mean, just the fact that she was trying an IOP program, you know, she tried different things, and she was very clear about what she believed would work and not work for her. Also within this time, I mean, she experienced plenty of grief and trauma in her younger years, but she also was experiencing this during this whole time as well. Just within our whole community, there was so much loss within the drug using community, and that deeply affected many people, including Amanda. And so another thing that happened when she got housed is, you know, she immediately became a place where others without housing could then be. She was always, you know, she always is, she's the type of person who likes to make other people feel happy and welcome, and she's really great to her friends. And so, you know, unfortunately or fortunately, however you want to look at it, you know, her apartment became very well attended, like I don't know, like just there was a lot of traffic in and out. You know, I think selling substances, you know, was something that she always struggled with because it's easy income, and it's not like anyone that we ever work with is like selling mass quantities of drugs. You're selling just to get by and to do what you need to do. And for so many women we see, it is a way, if you're selling, you're not engaging in sex work willingly or unwillingly. And so I think she struggled with that. But something that was great about that period of time, that even though she wasn't necessarily consistently connecting with Caitlin, or we couldn't see her because she wasn't, you know, at the soup kitchen or at the resource center, is I was able to connect with her and bring her supplies to her apartment. And she and I stayed very well connected during that time. And I would go bring her clean needles and clean supplies and Narcan, and I would take her dirty needles back to the office with me, and I would, you know, remind her to call Caitlin, or, you know, ask her where things were at. You know, with different paperwork that I knew, you know, Caitlin and I were able to work together and be like, hey, you know, we've got this coming up, or she needs to do this, or she said she wanted this, like, can we make sure this happens? And so I was able to sometimes be that connection for her, even when she wasn't out and about.
So we want to make sure we leave 15 minutes for questions, but I'll just kind of sum up. So, you know, some of the successes that I would say that we, you know, found in this collaborative work is that, you know, we never forced treatment on this person, and that if she refused treatment, then that didn't mean that other services stopped. So it was always her choice. You know, if she wanted to work on housing, but she didn't want to work on getting back in with a Suboxone doctor, that's fine. Like, we're going to take it at her pace and focus where she's focusing. And then we also always offered like harm reduction and safety planning conversations to her, especially once she was housed. You know, I was able to have pretty frank conversations with her about, you know, the types of risk that she may be encountering with having people she didn't know in her house, and how, you know, how was she going to set boundaries with people in her house, and, you know, what did that look like, and knowing that she needed to define that on her own terms. But I could also be really clear with her about, you know, sort of what we had seen before, and really, you know, just try to make sure she had all the information she could to keep herself safe, and keep her home safe, and, you know, do what she needed to do in her home in terms of the people who were coming there, so that way she wasn't in a situation where she felt like she had no options again. So that all felt like that. worked well. I mean, this is someone whose use is so chaotic, and she's still alive and kicking today.
Yeah.
We've still got her here, and she really struggled with suicidality over the years, and so it was really important that we acknowledge that, and acknowledge that that we wanted to make sure that that she didn't have an intentional overdose, for sure, but that she also didn't have an accidental overdose. And so that was just really important that she have access to that. Things that were hard about this case, there were a lot of them, but just in general, having a lack of movement or closure on her federal case was very challenging, and that wasn't something that was within her control, within our control as social service providers, but that still made things hard. And then just in general, the depression and the grief, as Zoe mentioned, just having things continue to pile up and accumulate, made daily life really challenging for her.
Yeah. Thanks. So I think as we wrap up our part, I think what we value the most in the work we do with any of the clients we work on behalf of is the relationship, and that relationship is really grounded in dignity and respect. And so we thought we would wrap up with this quote, and I'll read it. Each person's journey of recovery is unique. Each person must find what works for them. This means that we offer the opportunity to try and fail and to try again. In order to support the recovery process, mental health professionals must not rob us of the opportunity to fail. Professionals must embrace the concept of the dignity of risk and the right to failure if they are to be supportive of us. And I think in particular with the survivors of trafficking, this is critical. This is a critical way to approach that relationship when there's law enforcement involved who don't necessarily come from this perspective. So I'm going to just switch screens here and see if we can figure out how to find your questions. And thank you.
Thank you so much, Daniella, Caitlin, and Zoe. We are going to spend these last 12 minutes here trying to get to as many questions as possible that you've entered into the chat box. It looks like the first question is from Hani. Do you use buprenorphine? What types of labor trafficking are you seeing? And any reasons why you think you are not identifying more labor trafficking?
Well, hi, Hani. I wish I could see you.
Hey.
Hi. So do you want to talk about buprenorphine, or do you want to?
I mean,
Or you? Or
Yeah, one thing I'll just say is that, like, one thing maybe we should have made sure to mention earlier is that, so Maine is a state where Medicaid has not been expanded. So just to say that, like, we're operating in the situation where many of the folks we're working with are uninsured. And so that alone has been a really big challenge to helping people connect with treatment. And so through some of the ways that Amanda connected to treatment throughout her time working with us were through our client assistance fund. I think I'm trying to remember if we used law enforcement resources at some point, and then finding like grant funded spots as well.
Yeah, and then in terms of the question about labor, I think we are following the same path that many states do, where the focus is all on sex trafficking, and we are doing the best we can, and in particular with this partnership with NECAT, to really shift the conversation so that we're talking about labor and helping people identify labor. And I'd say of the labor cases we have had, there have been many forced drug trafficking cases that are just generally being overlooked by law enforcement, and that's just sort of it's an interesting way to think about labor trafficking, and I think a lot of people aren't. So next question.
Let's see.
I don't know if Sarah's.
So there was one question. I just tried scrolling up, and then so about clients accessing
trauma treatment?
Yeah, there was a question about clients accessing trauma treatment. So we do have the anti-trafficking program has a relationship with a substance use and mental health organization called Day One that provides counseling for the clients that we serve. And so Amanda was connected to this program at one point. And actually, she and her partner both went together for some sessions, and she had some on her own as well. And so that was, that was a period of time where she was, sort of willing to engage in therapy. But I think, it was really hard for her to go into a session, to have all of that stuff come up, and then to just re-enter her daily world. And so I think that that's something that was offered to her a number of times, like to, kind of continue with therapy, to reconnect to therapy. And that's something that as a program, we've, tried to get a better sense of who out there specializes in trauma, figuring out where to connect people. But for her, getting mental health supports was not something she was, identifying as something she really wanted to focus on, in part because she had had bad experiences as a teenager when she was depressed after the loss of one of her parents. So that was sort of where she came in going in. But more broadly speaking, we have been able to connect our clients, to various, EMDR and different options like that.
Yeah, and I think just to add to that is that it wasn't Amanda's priority. Right. That wasn't what she was identifying as a priority. Her survival was about day-to-day survival for her. And so because of her use, we partner with a particular agency that does the mental health and substance use disorder counseling treatment, and they're experts in trauma, and they have a low barrier approach to the way they do work. But many providers, if people are showing up under the influence, or if they're not showing up for appointments, the providers are not staying engaged with those clients. And so that's definitely a struggle, and something that we really that we're very conscious of, and work really hard to forge relationships with clinicians who recognize and understand the folks that we're serving.
I'm just seeing the question about how do you engage survivors whose substance use is used as an element of coercion by traffickers. So, I think that this would look different for different people. So there were some folks that we worked with who absolutely their use had been used as an element of coercion. For a period of time, I was doing the intakes for this program, and it was very common for me to hear experiences from people who may have thought they were engaging with a dealer who turned out to be their trafficker. And so someone would think that they were, able to get some free product for a little while, who thought they, might end up dealing. We did have several labor cases that ended up being, people who were forced into dealing, but it was really common for someone's to connect with the trafficker around substances, and then their substance use disorder to be part of their coercion. So for some people, part of what we were doing is like doing harm reduction work around, how to try as best as possible to vet the sources where they were getting their, their substances from. And some of the folks we worked with really identified that like recovery and absence and, getting away from the substances they were using was a way to keep safe. And for others, it wasn't. So it was, case by case is, what the survivor wanted to do at the center of all of that work.
And I would say that for me in the exchange, those individuals were some of the harder clients to try to engage in working with this group, and working with a caseworker or talking to Caitlin, because a lot of them did not feel like they were being trafficked. When I knew to a definition that is absolutely what was happening, I can't convince somebody, I can't make them access services, right? And so it's really hard. I work with a multitude of individuals, all happen to be young women who are currently being trafficked, exploited, but because they don't see themselves as victims, or as sort of in that box, which sometimes it does feel like a box. And I think, when I identify people, and I have to sort of see if they fit in that, and if they don't agree, then that's sort of where it stays. And the offer is always there, of course, and we always revisit it. But that's a huge one that I'm seeing right now, is just people not agreeing.
There's a question here about funders who are accustomed to different versions of success than how you or your clients define. I mean, I think for Preble Street and I imagine for the Needle Exchange, right? I mean, our mission and our agency is grounded in meeting people where they're at and in a human rights approach, so that like having access to basic needs and safety is a human right. And so it doesn't matter whether somebody has acute mental illness that's not being treated, or they have a substance use disorder that's not being treated. So we are lucky in that's we would never look for funding that compromises our mission and who we serve. And I would just say that OBC, who funds the anti-trafficking work, has been obviously a huge support to what we're doing and to addressing the issue of substance use, as they see a rising intersect with trafficking and substance use. And we do a lot of educating and have done a lot of educating with Department of Justice around this. So I think you just have to push it. What else? So I'm going to just scroll down here.
Sorry if we're not going in order. We're just trying to scroll around and see all the questions.
Do you have a specific program that focuses on life skills for human trafficking survivors? So not a specific program, but embedded in everything we do. It's really about, whatever the client identifies as a goal, we are going to support them around. So whether it's learning, whether it's connecting to school, whether it's learning English, whether it's taking driving classes, we are helping connect them to whatever those resources are in the community. We're really just that liaison and support for that person to try to reach those goals. So yeah, I think it's embedded in the work, but it's not like a specific separate program. And then there was a question about, is the labor trafficking mainly in the manufacturing and delivery of drugs? So we have seen that, but we've also worked with survivors of labor trafficking who were trafficked in the restaurant industry, in the farm industry in Maine, in domestic servitude cases. We haven't seen a lot of labor cases, but certainly a range of settings.
And I'll just add, so to Zoe's point about people and how people identify and whether people identify as victims or not, that also goes for like providers in the community. So this has only happened really for a handful of cases, but I will say I had times when I would get a referral for someone, and the person referring them would say, oh, this person has been trafficked for sex. And then they go and meet with the person. And actually what's happening is that person is engaging in commercial sex work in order to make money. And they're doing that on their own terms. But part of the reason why that has sort of come to play is because they've got like a really big debt that's maybe separate, maybe connected. We do see cases where someone's trafficked for both labor and sex, but I can think of a couple cases where there was someone who, as part of their life, had engaged in sex work at some time, wasn't engaging at that moment. But what was happening was that they were definitely under the thumb of someone who they had been getting, free substances for a long time. And I'm thinking of one case in particular of someone who was being forced to take on, really heavy criminal risk, moving substances across state lines. And this person she thought of as her dealer, had very personal information about the location of her children, her family, would routinely text her screenshots of sort of tracking coordinates. It was, very much a textbook trafficking case, but she wouldn't have identified it in that way. She would have thought, oh, I messed up and I got myself in debt to this person because, I'm an addict and I'm so out of control. When actually like laying out the situation of what had happened, someone had pretty strategically got her into, 5-figure debt so that way they could use her to shield themselves from criminal risk. And so, there are ways that we've seen those sort of labor cases come up that weren't identified at all as labor cases. They were identified as, whoa, here's this high risk person who's, connected to drugs and we don't really know what's going on. And then, through our screening process, we determined a little bit more.
I think that's it.
All right.
Thank you.
Thank you so much to our presenters today and for everyone listening in. We will be sending out the link to the recording from today. And we also want to highlight to you an upcoming webinar that we have next month. It will be led by survivor leader Jasmine Grace, entitled Sex Trafficking, Drug Addiction, and Recovery from a Survivor's Perspective. So we hope that you guys will join us for that. And as always, please feel free to email me if you or an agency you may know of is interested in receiving a NECAT training. And I think that's it. Thanks so much again, everyone, for joining us today. Hopefully see you next month.
Thank you so much.